Hello and welcome. My name is Stephanie Alband, and I'm Executive Director of Pheo Para. And I'm so honored to be here with this esteemed panel of experts in endocrine surgery. We are here as part of our sixth annual Awareness Week for Pheo Para. And it's an honor to actually do this for the fifth time with the American Association of Endocrine Surgeons in honor of Pheo Para Awareness Week. And I'm going to hand it over directly to them. But first, I'd just like to say thank you so much to the AAES Patient Advocacy Committee. I'm just going to see if I can hide another participant. There we go. Um, uh, Thanking the Patient Advocacy Committee for their organization of this webinar that is one of the highlights of our Pheo Para Awareness Week every year. So thank you to Dr. Lila Morris Wiseman, as well as the entire advocacy committee and everyone at AAES. So now, without further ado, I will go ahead and turn it over to our moderators who will introduce our panelists and provide an agenda and go ahead and get started. So Doctors Babenga and Ochoa, thank you so much for your time, and thank you to all the panelists. I'll hand it over to you.
Thank you so much, Stephanie, and thank you for allowing us the opportunity to join the Pheo Para Alliance in this Pheo Para Awareness Week. We are very excited to be here and discuss these rare tumors that are often overlooked. And we want to shed light on the patient journey, share current best practices, and highlight exciting advances in care for these patients. My name is Joanna Ochoa. I'm an endocrine surgeon at the University of Florida in Jacksonville. And I am joined here by our expert panelists and my co-moderator, Dr. Juliana Bobenga.
Hello, everyone, and it's wonderful to see you all, and thank you for being here today. I'm Juliana Bobenga. I'm an endocrine surgeon practicing at Matsu Regional Medical Center in Palmer, Alaska, also serving as a clinical assistant professor with the University of Washington, Miami School of Medicine. We're excited about our panel today. It's made up of leaders in endocrine surgery and endocrinology coming to you who routinely take care of patients with pheochromocytomas and paragangliomas. And they're really coming from all corners of the country between our panelists and moderators representing from California, Florida, Alaska, Texas, Kentucky, and Virginia. So we're going to focus on covering symptoms of these rare diseases, surgery, genetic testing, and changes that are coming on the horizon. We also want to make this interactive and try to answer some of your questions. We'll try to save some room at the end for your questions. I would like to ask the panelists to introduce themselves and let us know where they're from and what their practice is like. I will start with Dr. Kabebe. Maybe perhaps
the majority of responses were.
Sorry about that, maybe technical difficulties. Dr. Lee, do you mind introducing yourself?
Yeah, sure. I'm Courtney Lee. I'm a head of endocrine surgery at the University of Kentucky in Lexington, Kentucky, and take care of thyroid, parathyroid, and adrenal disease, and therefore take care of pheochromocytoma and consults on paraganglioma. We also, in our clinic, are the ones who run the genetic clinic for endocrine disease. So we follow many families with a lot of the pheoparaganglioma syndromes, all the SDH, obviously the MEN, MAX, all the different mutations that we see, and so follow a lot of families with with these diseases too, including those that don't have a known mutation but clearly have familial disease. So excited to talk to everybody. It's kind of like getting to be on a soapbox about a topic that nobody else really cares about except for those of us on this sort of call. So I'm really excited about it.
Great, thank you so much for being here. Dr. Electron Kabebe, do you mind telling us about yourself?
Sure, it's a pleasure for me to be here with you, Electron Kabebe. I'm currently at Stanford University. I am an endocrine surgeon. I operate on all endocrine organs except the pituitary and the breast. Pheochromocytoma-Paraganglioma patients, I feel, really need expertise care, not only surgical, but medical and a full team. So I'm delighted to join you today and answer any questions you might have.
Wonderful. Thank you so much for being here. Dr. Hamidi, could you introduce yourself too, please?
Hello, my name is Oksana Hamidi, and I'm your token endocrinologist for today. I practice at UT Southwestern Medical Center in Dallas, Texas, and I primarily see patients with adrenal disorders as well as endocrine neoplasia syndromes. So that's basically majority of my clinical panel. And I also do clinical research in all things adrenal. And my main role today and always is to first keep my surgeons happy, and then to also lead patients in their preoperative phase, but also postoperative follow-up. So I am happy to be here and look forward to next discussions.
Thank you so much for being with us tonight. And we also want to offer congratulations to you and UT Southwestern, which has been recently designated as a Pheochromocytoma-Paraganglioma Clinical Center of Excellence, similar to Stanford's and Dr. Kabebu, who also is part of a center of Pheo and Para Clinical and Research Center of Excellence. We also may be joined by Dr. Mary Beth Hughes from Eastern Virginia Medical School. And she may or may not be able to join our panel tonight. There were some delays in the OR today, and so we're not sure if she'll be able to make it or not, but hopefully she can. I'll turn it over to Dr. Ochoa.
Thank you. So I will go ahead and get things started by recognizing the zebra in the room. So these parentheos are often called the great mimickers. Their symptoms can be vague and sometimes really nonspecific. Let's start by talking about how sometimes these patients can be misdiagnosed. And how do you really approach diagnosing these patients when they come to see you in clinic, Dr. Lee?
We all learn in medical school about the classic triad of headaches and palpitations and sweating and whatnot. And every once in a while, I'll have a patient that actually has all of those at one time. And that's kind of exciting. But that's not just like everything else in medicine, how it always occurs. So somebody may have one of those or several of those. Had a young patient years ago, and the only thing was crazy sweating. And I didn't even know there was a sweating workup in the Universe of Medicine, but he had had the entire thing, and nobody thought of Pheo until he presented in adrenergic crisis and almost died, sort of thing. And so it can just present in so many ways. I had a patient that just presented with not diabetes, but that is a way, presented with diarrhea, which is not something we usually think of, but that was kind of the presenting symptom. So the two different ways we can find it, obviously, are with presenting symptoms. And unfortunately, in my experience, those are not usually recognized, and Pheo is not on the differential when a lot of those come in, often misdiagnosed. I've had a new patient coming in now, and one I just operated on that presented with hemorrhagic stroke, and it wasn't really diagnosed during that until it was found incidentally. Others with MI, the sequela of the disease that we see. The other way is we find an incidental nodule, and obviously the diagnosis there is biochemical. So I feel like in this world, we're either getting a lot of false diagnoses of people that are terrified somebody has a Pheo when it's a false positive lab tests, which are quite common, or people that have clinical presentation of disease and nobody thinks of the diagnosis. And so that's what's interesting, I think, to me, talking to all of the different patients about how many times they've presented with different things. And in retrospect, I always know about it because that's what I'm doing for a living. So I'm like, oh, how could they not know that? But it's, there's such varied diagnoses. So that's interesting to me.
And as you mentioned, nowadays, because CTs and MRIs are done for lots of different reasons, especially, in trauma situations where the people are just getting scanned, and we find all these things. So in a patient that comes to see you and they have, elevated adrenaline, and no other symptoms that you can recognize, how do you approach that patient and counsel them in terms of, do they need treatment and why if they don't have symptoms?
You're talking about somebody that does have an adrenal lesion.
Correct. Yeah,
Yeah.
all their
So you've made
biochemical
them.
testing is positive.
Yeah, well, I always joke on the way that I explained it to my 5-year-old back. He's 17 now. Life goes by quickly. But anyway, he would be like, Mommy, my mommy does pheochromocytomas. And he would tell his friends that. And he would be like, it was in a tumor and it's so much and it makes the heart explode. And I'm like, that's not exactly how I described that to you. But when you talk about it, the tumors, when they just cause episodic high blood pressure and they cause the palpitations and that kind of sense of impending doom or that feeling that something bad is going to happen, those are not welcome symptoms, but those in and of themselves don't cause problems. But sometimes those tumors can be dangerous and can cause an adrenergic crisis. And that's what we're really trying to avoid. So in my practice, I think an unblocked Pheo or undiagnosed Pheo in the wild, as we think about it, one of these zebras in the wild, that's what makes me kind of one of the most nervous. And then once we can get people blocked appropriately, it's safe. So that's why we want to take these tumors out, because they can be mean in making way too much of that adrenaline at one time and causing significant harm to a patient.
Thank you. And Dr. Hamidi, when you're seeing these patients and evaluating them for a Pheo or Para, what are some of the things that you often diagnose them with instead of that, if you're looking at your differentials?
And that's a great question. I'll just try to highlight points that maybe were not brought up, but in endocrinology world, there are basically 3 buckets of presentations when it comes to Pheo workup. And that would be the first category when we are thinking about it. If the patient is presenting with all classic symptoms, and maybe some of them are less common, but still they have a lot of symptoms. That's the first bucket of patients I would call when we start with biochemical workup. And in that setting, when the patient has a lot of symptoms, we would expect those levels to be moderately or even severely elevated. These will not be borderline or normal biochemical results. The second panel or the second bucket of patients is actually what we now call a modern Pheo. And these are patients that diagnosed with Pheo, excuse me, completely incidentally. So this is an incidentally discovered adrenal nodule that further leads to testing, and that's how we diagnose patients with Pheo. These patients may be completely asymptomatic, especially with baby Pheos when they're small enough not to really have enough factory to produce catecholamines, adrenaline, to really cause all these classic symptoms that we learned about in med school. And I would urge that that's actually the modern Pheo, because at least 60% of patients are diagnosed with Pheos in that fashion. The third bucket, maybe a third of patients, is actually when they come to us with a genetic testing that was positive for a mutation that increases the chance for hereditary Pheochromocytoma-Paraganglioma syndrome. And that's when we work up patients. Again, they can have completely no symptomatology. Their biochemical testing can be normal, but even in those patients, we periodically screen them with imaging without any symptomatology or biochemistry.
Well, that's a great way to categorize different ways of presentation. And I wonder, patients who end up having head and neck paragangliomas, where do they fall? How do they usually present out of those 3 categories?
So head and neck tumors are oftentimes non-functioning. What that means is on test, they don't show up positive. So their adrenaline levels in the way we measure them are normal. And oftentimes the only symptoms that would be from mass effect or completely incidental when they have injuries or sinus issues and they scan and we pick up those tumors. And another category when they have a genetic mutation and we discover tumors just based on genetic mutation screening protocols. Those patients can have ringing in the ear, they can have dizziness, vertigo, or feeling like something is their throat, or even seeing a mass in their neck, or again, completely asymptomatic. because typically those tumors are non-functioning.
Yeah, that makes sense. Thank you. And how is it best that we can support and help these patients with the rare tumors? Because we know that it sometimes takes them a while to get to the experts, to people with a lot of experience.
The scariest thing is for us to miss this tumor. So we have to have very low threshold for testing. And we have great biochemical tools to really diagnose this tumor or exclude it, as well as imaging tools that help us with this. And also in a context of improved genetic panels, when we can potentially even screen patients that don't have these tumors. So all of these are on our list of kind of how we improve care for these patients, but ultimately having the lowest threshold for testing. And by that, I mean biochemistry. And then also really recommending, and we'll talk about that a little bit later, but really recommending genetic testing for patients who either have paragangliomas or pheochromocytomas, but also family history and other context.
Dr. Lee, go ahead.
The other thing that I was going to bring up is it is such a rare tumor that it's important for these types of tumors to be seen by somebody that is an expert in that, a center that knows how to deal with these tumors and can really not only deal with it and treat it, but diagnose it. They're not always the easiest to diagnose and understand what's going on, but also be able to explain to you. It gets complicated because a lot of them are genetic, almost half now. And so I think that's important. Looking at, both of the hosts of tonight's meeting, the American Association of Endocrine Surgeons on the AES website, there is a physician finder link. There's a lot of good information that you can look at on there about Pheo and paraganglioma, but most importantly, help find a team that'll be familiar with these diseases and help with that. And then, the Pheo Para Alliance, having an organization like this with other people who have been in your shoes and kind of know what it is you're talking about can kind of help prepare and ask questions. Basically, a pre-made village whenever somebody finds themselves in these shoes. I think those are great resources especially for such rare diseases like this one.
Absolutely. Those are great starting points and great ways to, great resources to get you to the experts. I'd like to move on to discuss imaging of these rare tumors, which can be very helpful in helping us manage these tumors. Would you mind discussing, Dr. Lee, what kind of imaging you use and perhaps different imaging in different situations or for different purposes?
Yeah. As the surgeon, often the patients have come to us and already have imaging. And so if we are looking for pheochromocytoma or somebody that has that diagnosis and they haven't been imaged, which I almost never see because it's usually been imaged by the time I see them in that boat. But a CT scan is going to be a great test just to find if there is a mass in the adrenal or if there is a paraganglioma. So that is just a plain, cross-sectional image. We can see if there is a tumor. That doesn't tell us specific things about the tumor, but if we know we have a Pheo based on the blood work, and then we have a mass in the adrenal, that's a nice, easy way to do it. We may not need more. When we have patients that we know have a genetic syndrome and do not have a biochemical diagnosis, then we are going to do imaging to look for tumors that are either too small to be positive yet on blood work or aren't functional. So paragangliomas, like we talked about in the head and neck, tend to not make hormone, and some of them in other places don't either. And so, we usually will start with a whole body MRI, and some of the recommendations are doing MRI of everything except for the thorax and doing a PET CT, or the newest consensus for SDH mutations. But anyway, we're going to do imaging and see if we can find a tumor that isn't making hormone. When we have a patient with a genetic syndrome with a Pheo and we're suspicious of multifocality, because if you have a genetic syndrome, there's a higher chance that you might have one in the other adrenal. And so when we take you surgically to fix the problem, we want to make sure we fix the problem. So we want to make sure that we address all of the disease that you may have. So that's where functional imaging can be useful. And now a dotatate PET would be the test that I would go to first if I was going to do functional imaging and try to see if we had multifocality or distant disease, if we were worried about malignancy, if we had a large tumor or something like that. MIBG used to be kind of the primary treatment, and that's a nice functional study as well. That can be nice, especially if you're considering therapeutics for distant disease, et cetera. So, but anyway, CT scan would be kind of the first if you were just worried about a good old-fashioned Pheo. MRI is a study we use for screening if we don't think somebody has a tumor. There's certain characteristics on MRI of somebody if you think they do, but I think if you have a mass in the adrenal, you have biochemical evaluation, then you have a good diagnosis.
Excellent. We know that some of our patients get FDG PET scans. What is the utility of that in pheochromocytomas and paragangliomas?
Not great. The problem with FDG PET is a lot of things light up in the adrenal that just different adrenal tumors that aren't even necessarily functional. So it's not very specific to tell us, oh, that's a Pheo. So I think dotatate PET would be much more preferable. We don't really use the FDG as much, at least in our practice.
Excellent. Thank you. Dr. Ojo?
Let's move on to talking about things that we do to prepare a patient for surgery who has a functional pheochromocytoma or paraganglioma. This has changed over time. A few decades ago, everyone was being prepped to go to surgery with phenoxybenzamine, which is often now a medication that is not easy to get and sometimes very costly and not something that we can always give our patients. So that has shifted into other medications, different types of medications, and also some people maybe even saying maybe we don't even need to prep these patients as much as we did in the past. Dr. Hamidi, can you comment on what is your preferred management in getting a patient prepared to go to the operating room, and what medications that you like to use?
Certainly. So it's an interesting question. And of course, there are pros and cons to considering whether or not to alpha block. When I trained, we were taught that everyone needs to block. So that's still my go-to strategy, mainly because I don't work in isolation. I work with my anesthesia team, with my of course, my surgeon, and it's very important that the team is on board with this strategy. So in certain centers, when especially smaller tumors, patients are not having a lot of symptoms, or maybe their blood pressure is relatively normal or slightly elevated. And in those situations, as long as you know what kind of surgery you're subjecting the patient to, specifically knowing that you're going after Pheo, when you can inform your anesthesiology team and just be aware how to handle that surgery intraoperatively with certain medications that should be given or maybe should not be given if the patient or when the patient has Pheo, to really make sure that they get through surgery safely. So generally what we do is we follow the Endocrine Society guidelines, which recommend for tumors, even when they are biochemically negative or asymptomatic, to still go ahead and alpha block them. And generally we use 7 to 14 days of preoperative alpha blockade. And that's the time when we would communicate with the patient on pretty much daily basis. They would inform us about their blood pressure, heart rate, symptoms, orthostatic vitals as well. And then we go up on the dose up until the day of before surgery. Then they have their surgery. And of course, after that, they hold the medication. And generally, we kind of touch base with our anesthesia team and endocrine surgery to really know how we did, how the patients did, of course. The biggest concerns about perioperative phase for patients with Pheo Paraganglioma is concern about hemodynamic instability, meaning when their blood pressure gets dangerously high, and when the tumor is resected, their blood pressure can get dangerously low, or you can have up and down roller coaster type of situation. So anesthesiologist really needs to know which specific medications to use during these both periods to really keep the patient as safe as possible. Again, to this end, there are many centers that are very comfortable with not alpha blocking these patients. The rationale for that is that actually, specifically in those cases when the patient has normal blood pressure, less symptomatic or smaller tumors, when we give alpha blockers, which are these medications like phenoxybenzamine or doxazosin more commonly, patients tend to, we see similar blood pressures during the operative period, but they tend to have more hypotension, low blood pressure after surgery, at least from the reports. The issue with that is all of these reports that we have are, many of them are observational or retrospective, meaning this is just how we do, we look back with what we did. And that introduces a lot of bias. So we have to be careful when we interpret these studies and ultimately truly work with the patient, keeping their best interest in mind and our team.
Thank you. And Dr. Kibebu, when you're preparing a patient to go to the operating room with the pheochromocytoma, sometimes the doxazosin, it comes in very, very small pills. And sometimes patients are like, is it okay that I'm taking all these pills? And there's so many of them, even though they're very small dosages. But do you think or is there any problem into increasing that dose quickly over, a week or two before surgery? And what's your experience in getting these patients prepared for surgery?
Yeah, I mean, I think it's the most important element of what I do. So usually with doxazosin, actually do it every 3 days. So what we do is once we start them, tell them to take a diary of their blood pressure in the morning and the evening with the heart rate, and to send that to us every 2 to 3 days. And once we look at the data, usually adjust the blockade accordingly if they're still hypertensive, and also talking to them on the phone to see if they're symptomatic, especially if their symptoms are getting better. Another element of that is making sure they're staying well hydrated. And when it gets close to the date of operation, we usually tell them to eat salty food, chips, potato chips, in preparation of expanding their plasma. So it has to be a real time, interaction with the patient that's taking it, looking at their symptom, where their blood pressure is, and increasing it every 3 days. I've postponed procedures for a week or 2 weeks if we're not there yet. Sometimes we've moved it up when the patient is sort of, so to speak, in the sweet spot, and have had their procedures done earlier. So that's generally the strategy. And I'm fortunate to be at my institution, the anesthesiologist. We have a group of 5 that do these cases with us, and they're actually in that My Health message. So everybody's getting, in addition to the endocrinologist, is getting it, and we're sort of doing it in a consensus. The surgeon takes the lead, but with input from everybody. Did that answer your question?
Yes, that was perfect. Thank you.
Dr. Lee, is there anything else that you would add in the preparation for the patient for surgery?
Yeah, just a couple comments. There is a lot of data about doing it with no blockade. And I think in certain centers, and most of that data is out of Europe and whatnot, maybe doing it for small tumors. As I tell my patients, this is not something I want to be caught with my pants down. Like, we're just going to block everybody. Like, it doesn't make any sense to me whatsoever to try to be all fancy and not block. Like, you can only wish you didn't. Do you know what I mean? And so we
100%.
block patients until they get a little orthostatic hypotension. If they're a little dizzy when they stand up, then we're like, okay, we're good enough. I think the other thing that's important, y'all heard me say earlier, I get all nervous about unblocked Pheos out in the wild. Once somebody's blocked, they're safe. And so I've had several patients that have presented with, oh, they've had an MI or they have this arrhythmia and we're going to do a not Hartman procedure, a Watchman or whatever the heck. They'll have something that they need to be in anticoagulation for 6 months or so. It is safe. to wait until they can come safely off of anticoagulation if they're a reliable patient that's going to take their medicine and do their thing. So we've had to do that more than once because of they presented with crazy adrenergic crisis and had bilateral PEs and or pulmonary blood clots to the lungs and end up having to be on blood thinner. We want to wait until it's safe. So once we get people blocked on those medications, it is safe to wait and do surgery when it's safe to do surgery. So I think that blockade is what makes this the safest. I was probably a hang up on phenoxybenzapine longer than everybody else. Until I was first author on the Pheo Paraganglioma section, and that was what I had to look at if it was as safe as doxazosin. There is no difference in the morbidity mortality between those two, but the phenoxybenzamine the data does show that it is less intraoperative variability. And once again, some post-op hypotension, bring it on. I'll give you some fluids. I'd rather have that than instability. And so once again, with the blockade, we block everybody. But I think if you have the right team, the right anesthesiologist, all the things, you can do all kinds of things in the universe safely. That's just not one I'm eager to jump on.
I just wanted to quickly add that we discussed about alpha blockers, like selective, non-selective alpha blockers, but there are additional medications that sometimes we have to either add on or use, especially if patients say don't tolerate alpha blockers. So we can use calcium channel blockers, and there are also studies, small studies, but show that that's a potential alternative. And then also metyrosine, which is a much more rarely used, but usually used in cases when we expect a huge catecholamine adrenaline release during the procedure. And that's something that we also have access to, typically done when a patient is hospitalized about 4 days before the surgery. And lastly, many patients develop increased heart rate, we call it tachycardia, and may need to have a beta blocker added, especially towards the end of the blockade, a few days before surgery when their heart rate goes up, and or sometimes even calcium channel blockers. So in addition to volume status, salt, and actually we can do pickles, which are then not chips, just by the way. We have a whole menu for patients and they're like, wait, come again? So yeah, they usually go to town with all the fast foods, but also there are some less, still high salt, but maybe less weight gaining type of options for this. And it's short, but they usually kind of have fun with that as they're getting ready for the surgery. So I just wanted to add that there are some other medical strategies for this.
Thank you for that. I really appreciate your example of a pickle. I've never even considered that, and also tell my patients to have some chips. So that is way healthier. And yeah, I'll have to
I
look
have
at
a whole
other
menu.
healthier alternatives. Yes.
All these electrolytes that are sugar-free now, they have a gram of sodium in one, and they actually taste amazing. So there are so many ways to do this, not just chips, but usually patients don't mind if you say you can have chips.
Nice. Those are excellent points. How about after surgery? Do the surgeons like to have the patients spend time on a regular unit or a specialized ICU unit, or does anybody discharge patients after surgery? How do you manage the patients after surgery, Dr. Lee, and then after that, Dr. Kabeba?
Sorry, I was reading the chat to myself. How do I manage these patients after surgery? Sorry, yes.
Yeah, just do you keep them on a regular floor or in the ICU, or do you discharge them the same day? How do you take care of them?
Sorry about that. Yes, that's a good question. So that is something I've also changed. I used to send them all to the ICU, mainly because I wasn't as trusting of what would happen on the floor. So for years I did that. Now I send them all to the regular floor. And I think it's important just based on where you work and who the teams are. Ironically, the reason I now send them to the floor, I used to always do the Pheos at our main huge academic hospital, and now we're doing them at the hospital where we do most of our endocrine surgery. And at our current hospital, I have more control over the patient when they're on the floor than I do in the ICU. And so that is most safe for me. If I give the patients my cell phone numbers, even when they're in the hospital. I just want to know when things happen. Most of the time they don't need anything. You know, I used to put people in the ICU because, oh my gosh, what if they need a pressor to keep their blood pressure up after the surgery or whatnot? Even my patients with multiple bilateral Pheos and levels 80 times upper limit, they don't really get that hypotensive, and I haven't had any of them that have really needed much pressor support overnight that would require the ICU. So usually, if anything, it's a little bit of fluid and they usually level back out. So I now send them, that's a long answer, but I now send them to the regular floor afterwards. But I think it depends on where you work and what type of nursing and whatnot you have.
Excellent, sounds good. How about you, Dr. Kababa?
Yeah, we always set them up to be admitted to the SICU, the surgical ICU. So everybody's scheduled that way. Does everybody go there? No. That's a game time decision based on how the patient does in the operating room. If there's no blood pressure lability, then they could go to the floor. If there is, or we're concerned, significant hypoglycemia, then they're all set up to go to the ICU. We're not trying to get them an ICU bed. So it's really, for planning purposes, just much easier to set everybody up to go to the SICU. Well, what does that mean? Many patients go home directly from the ICU the next day because they've stabilized. But to me, it's sort of, added insurance that we don't have to worry about getting a bed for a person that might have a labile blood pressure during the case. Because of that approach, and I think this is appropriate for the many patients, is the insurance companies sometimes give us a hard time. And that's actually something, and I even had a peer-to-peer where the other physician from the insurance company told me, oh no, other places don't even admit these patients, which I almost had a stroke when I heard that. So we're actually looking at the national inpatient data and providing data, hopefully in the near future, so that we don't have to deal with authorization and peer-to-peer just to be able to admit a patient with a pheochromocytoma or a paraganglioma to the hospital. So it's interesting to hear what Dr. Lee does. Perhaps other centers really do it as a outpatient procedure, but I was shocked to hear that. So yeah, set everybody up to go to the ICU. I think most don't end up going to the ICU, but it gives us that cushion because we're pretty impacted with our census. We're always over 800 beds that we have. So for planning purposes, it's just easier for me to do that at my institution.
Excellent. Yeah, that's in line with, I think, what most of us endocrine surgeons choose to do after surgery. Wanted to bring up a couple points and questions from the chat and Q&A. Some patients had some great recommendations for high sodium foods, canned vegetables, canned soups, soy sauce, and salted caramel chocolates.
Nice.
Just if anyone else needs ideas. And a patient asked, after surgery, do some patients need steroid replacement after pheochromocytoma replacement? And maybe we can start with Dr. Hamidi on that, but everyone
I
else
was gonna
is
say, I
welcome
bet
to
you
weigh
want
in.
me to take that question. So yes, in certain situations, we do actually already have a plan in place of what kind of steroids to start. And typically this is in a setting when a patient has bilateral pheochromocytomas, when we are anticipating it, even when the anticipation is to do it as a cortical-sparing type of procedure. Still, there's a pretty high risk, up to, some studies say up to 40%, that even with cortical sparing surgery, that still patients may develop permanent adrenal insufficiency. So this will be the case when we would say that's the protocol. And then another situation would be if the patient had prior adrenal surgery and we are going after the remaining one. Those will be the cases. But if patients only have unilateral pheochromocytoma resection, meaning only one adrenal gland is removed and the other one looks healthy, normal, there's not a tumor sitting on it, then generally the chance for having to go on steroids for that in that situation is very low. As long as there's at least 10% of the healthy tissue preserved, generally that's enough to maintain steroid production, healthy steroid production function. We want to avoid steroids for patients who are about to have surgery for pheochromocytoma because steroids can actually activate adrenaline release, and that there are many cases. Unfortunately, we also had a patient like that who got steroid injection for his joint pain, and he unfortunately presented with catecholamine crisis. It was just really, really devastating. So we try to avoid them before, especially if the patient is not even alpha blocked, but it can still happen. So we try to avoid it, but certainly have a plan for postoperative. Steroids and for primary adrenal insufficiency, they often also need fludrocortisone, not to be forgotten.
So can I jump in there and ask questions?
Sure.
So at my institution, if we're doing cortical sparing, either the other adrenal gland has been removed and a pheo occurs in the remaining gland, or it's bilateral disease and we're doing cortical sparing, I routinely will do a co-syntropin stimulation test the following morning, or if the patient is going to be there for 2 days, the postoperative day two, and kind of use that to guide me. That's what I've done when I was at UCSF, at the NCI and NIH, and then now here at Stanford. I'd love to hear your thoughts about that. Do you find it reliable? Because sometimes I feel like some of the patients end up on steroids and they never get tapered up because everybody's scared to take them off.
Yes, absolutely. And we have a really close collaboration with our surgical colleagues to do the same for pheo surgery in this particular setting when we are going after either the remaining adrenal gland or there's something wrong with the other one, like there's a tumor there or something we're not sure about, or with cortical sparing when we know that there's still a chance. Ultimately, there's a good chance that they will not have adrenal sufficiency, and we don't want to subject these patients to steroids unnecessarily. As long as we have an understanding that these patients will get tested shortly postoperatively, typically the morning of post-op day 1, and co-syntropin stim test is actually quite good because we are testing for primary adrenal insufficiency when the test has very good diagnostic value and really can tell us about the reserve of adrenal function. As long as that can be done safely and relatively quickly without any delay, then I think that that's the best way to approach this, as opposed to treating everyone empirically, meaning just giving them steroids just because we suspected. So that would be my approach. But some of us might not have that either communication style or maybe even access to endocrinologists or surgeons, or sometimes patients refer to endocrinologists by outside or to a surgeon by outside endocrinologists. So if there's any concern about it, then I would rather stay on the side of caution and treat that patient because adrenal crisis could be life-threatening.
Excellent. Those are great points to bring up. When we talk about pheochromocytoma and adrenalectomy, there are many different ways to do an adrenalectomy, whether it's laparoscopic or open or robotic or retroperitoneal. But the surgeons want to share the type of adrenalectomies and how they approach pheochromocytomas.
Well, I will, you want your tumor out without the tumor being disrupted for the pheo, and you want somebody that, it's kind of like a video game in my mind. We're trying to get the tumor out without touching it as much as we can. And so you don't want to manipulate it or push on it too much if you can help it before you get the vein divided. And so I think that a lot of that is why you want to be in expert hands. But the preferred way to take them out is minimally invasively. That means with the small cuts in the camera. And you can do that laparoscopically or retroperitoneoscopically, which basically just means we use a camera and our straight little sticks with the little instruments on the end and we do the surgery. Or you can do it robotically, which is the same thing, the same sort of ports. You still have sticks in there, but instead of the sticks opening and closing this way, they can turn and do more stuff. And so you sit at a console and do that. I don't do robotic surgery now. Learned some of it in my fellowship, but for me, it seemed like a long run for a short slide, and so I don't do it. But you basically want to do it minimally invasively for the most part when that's possible. Sometimes it may not be if there's concern for cancer invasion. I prefer the retroperitoneal approach, which we have the patient on the belly, face down, and we go under the rib on the back directly into the space where the adrenal lives. We have, less opportunity to kind of mess around with stuff or move as many things out of the way. I tell my patients God hid the adrenal. It is in a hard to get to location. It's back up over the kidney, behind the ribs, behind the liver, behind the spleen, behind the pancreas. My mentors used to go and have to take out a rib and all kinds of crazy stuff to get back there. So it's really nice that we can do it minimally invasively. And I like going directly into that space. Body habitus, so a large patient sometimes is going to make it more difficult to go through that retroperitoneal approach, and the other ways to go through the belly. So we would put a patient on their side with the operative side up or the side of the tumor up and make the little cuts under the rib cage, kind of like a patient may have for gallbladder surgery, and go and take it out that way. And then, like I said, sometimes we would have to do it open, which requires a big old incision because it's kind of hidden back in there. And we would do that if we were worried about it being invasive or reoperative surgery or kind of more unique settings.
Excellent. Dr. Kaboga, what's your approach surgically?
I thought that was beautifully covered by Dr. Lee. I do, I think minimally invasive, that's a term that to take away from the session. If it's a small, not likely cancerous tumor, you want to have it done minimally invasive. I'm old enough that I do it all the different ways. The lateral, transabdominal, I do it retroperitoneal. I use the retroperitoneal approach mostly for patients with bilateral tumors or smallish tumors. I use the lateral approach for patients with larger tumor, or like Dr. Lee, when there's a lot of retroperitoneal fat and you're kind of from the back trying to reach the adrenal gland. I've done it robotically. Why? Because the fellows wanted to learn how to do it robotically. I would say at this point, very few that I do robotically, unless a patient came in and told me, I want you to use the robot, and I'll tell him it really doesn't make a difference. It might take me 20, 30 minutes longer than if I did it lateral approach. So the take-home message is really the outcome is much better for minimally invasive. And, there are studies out there that compare a lateral approach versus a posterior retroperitoneal and tell us, oh, they recover much faster, et cetera, et cetera. And really the outcome is not that different though, because usually people compare their old data and then compare it to the new way they were doing it. And guess what? You get better as you do more of it. And all of a sudden, this new way is the end all be all. So take home message, make sure if you're going to have it done, it could be done minimally invasive. Get it done that way because you'll be in and out in the hospital, back exercising, back to work much faster.
Do you have a preferred method, Dr. Ochoa?
Yeah, I mean, I agree with everything that has been said. I will do it robotically transabdominal and, just do it the endoscopically or laparoscopically, retroperitoneal, and base everything on the patient, their body habitus and tumor size. Definitely in fellowship, we did everything through the back. And then, when I moved and started my practice, it was a very different patient population, and realized that doing it through the back is sometimes not always worth it. But certainly then I get patients that have had, 3x laps and a lot of abdominal surgeries, and you're expecting a lot of scar tissue around where the adrenal is. And then it's, definitely not worth it to go through all of that again. And I will definitely go through the back, even if I think it's going to be a little bit more complicated. So I definitely want to specialize it to the patient, but I am all for minimally invasive. So I'm going to switch gears a little bit and talk about some paragangliomas. So just in the most simplistic of terms, paraganglioma is essentially a pheochromocytoma that's not in the adrenal gland. Can be anywhere from the base of the skull all the way down to the pelvis, and the approach for these can sometimes be a little bit different. Dr. Kibebu, can you talk about in terms of what kind of workup you may do for these patients and what your surgical approach is, whether it's in the neck or along the aorta in the abdomen?
Yeah, I'd be happy to. So, as you stated, the paragangliomas are not in the adrenal gland. By virtue of that, they might not secrete uh, catecholamines, right? So I often will check a chromogranin A because it's a good, reliable marker, and that's something I will have after it's removed as a baseline when you follow patients. For imaging, I use both CT scan and MRI to define the lesions. I find the MRI really, if it's a big tumor, gives me an idea if it's invading the surrounding structure. You could define the planes between the tumor and the surrounding tissue better. So that's what I use for imaging. Now, we talked about how some patients with Pheos at some centers are not blocked. I actually, even if I do biochemical testing, their norepinephrine, medinephrine fractionated is not elevated, I always block them. Alpha-blockade, because why? I've been there without a patient blocked with a carotid body tumor, resecting it, and the patient's blood pressure went through the roof. So I think it's just better to block them before the procedure. And then if it's in the abdomen, I still approach it minimally invasive if I'm not worried it's malignant. If there's obvious involvement of the renal vessels or the aorta, then I do those procedures open. Multidisciplinary planning is super, super important. So I've done paragangliomas that invaded the aorta where we needed to take, or the vena cava, and we needed to take a portion of it. So having vascular surgery, not just available for the operating room, but actually we discuss these difficult cases in a conference where they're present and preparing appropriately, I think is very critical. If it's not likely to be malignant or locally invasive, then, I would approach it minimally invasive. For the head and neck paraganglioma, it depends upon the location. If it's a carotid body tumor and it's super large, we've embolized some of these, and it's important if you embolize them, you don't do it a week beforehand. You do it literally the day of the procedure or the night before the procedure. And then that case is also, we've usually had vascular be aware of the patient, discuss, because some of the tumors invade the wall of the carotid body, in which case we need to shunt them. So being prepared to do that. Um, if we're really worried about it, we do an occlusion test preoperatively. What is that? We occlude the carotid, the internal, and make sure there's adequate contralateral perfusion and that the patient is going to be fine. If that's the case, then we don't need to shunt the patient. We could go ahead and resect it and just do a primary repair. The other locations, quadia tympani, as you get higher up in the skull base, fortunately now with CyberKnife, I think that's actually a much better approach for those patients that doesn't result in the significant morbidity of surgical resection. And mostly the otolaryngologists at my institution do these operation. And then to step back for paragangliomas in my surgical approach, or even whether to intervene, I find that the genetic data, knowing what the germline mutation status of the patient is super, super important. We've monitored 2.5, 3 centimeter carotid body tumors if they're not SDHB or D associated. Why? We've done natural history studies when I was at NCI, and over 15 years, none of those tumors progressed. Versus an SDHD and SDHB, even if it's a centimeter tumor, we'll go ahead and resect it because the likelihood of it progressing is significant, up to 15% over a 10-year period of time. I could go on, but I'll stop there.
Well, as you mentioned, some of these tumors can, even if they're small, can be quite involved in whatever the vasculature is near it or the nerves. And surgery can sometimes cause much bigger problems rather than not doing anything at all. One of the questions from the audience members was, what are your thoughts in embolization for non-operable management of these difficultly localized tumors?
Yeah, that's a phenomenal question. You know, the embolization really works well to cut down the vascularity of the tumor. And remember, I was saying you need to do it the night before or the day of the procedure, which unfortunately happens is once you embolize it, it recanalizes. So the blood flow kind of bypasses. Think of it as you're in LA and there are multiple freeways you could take. You know, you could embolize maybe one or big, two freeways, but there are other ways to get from point A to point B. And it's not a durable way of shrinking the tumor or keeping it in check because these tumors are basically a bag of vessels, so they find collateral blood flow and continue to grow. So it's only a temporary fix.
And then as we just have a few more minutes, but we'll try and get some other good information review. When we're looking at pheos and paragangliomas that have spread or become metastatic, what are the most exciting treatments that are up and coming now that you're excited about using in your patients? And what are the typical things that you use to treat patients? We'll start with Dr. Hamidi.
So I would say that even in patients with metastatic Pheochromocytoma-Paraganglioma, what we've shown is that, at least in retrospective studies, when we look back, is patients who, even in that setting, were still able to have surgery, they tend to do better, especially when tumors are functioning. So even though we know that they have metastases, then still we might discuss in those particular situations if surgery is an option to kind of take out the bulk of a tumor, and that typically also helps us manage the smaller disease. We also consider utilizing minimally invasive techniques like ablative techniques when we zap, not we, but the interventional radiologist will zap something with freeze it or heat it, or sometimes it's a localized radiation if the tumors are not resectable, but say symptomatic, causing a lot of symptoms, pain, adrenaline release, whatnot. So, but also we have some systemic therapies, just like what you would think about chemotherapy. So there are more traditional chemotherapy, especially for patients, for example, who have SDHB. They tend to react to CVD regimen, which is the chemotherapy regimen, a little bit better than patients who don't have SDHB mutation. We also have been using in the past Azedra, which is a high sensitivity MIBG type of therapy, but unfortunately that's no longer available. And other therapies would include Lutathera, which is basically for tumors that are positive on these dotatate PET-CTs. We can also use lutetium-177 to also treat it, which is the term we use for this as theranostics. If they positive on a scan, they're likely to respond to these therapies with Lutathera is one of them. And then also there are some clinical trials ongoing with immunotherapy. I would also add that with all of these available treatments, we often discuss a possibility of getting the patient enrolled in a clinical trial. And I would say that maybe this is for many of them as a go-to strategy, especially when surgery is not an option. A lot of these other options are, we suspect, are likely to fail. So that's another consideration, getting enrolled in a clinical trial, especially if that's a possibility.
And just to round out, I think it's a game changer, the HIF2 alpha inhibitor that was just approved for unresectable metastatic. I've seen patients with VHL that were on it for renal cell carcinoma, and we've been hemming and hawing of whether to remove their Pheo, where their Pheo actually shrinks. So I think it looks very promising if the metastatic Pheo paraganglioma is hypoxic that subgroup that it's very likely. So I think that's an exciting development that the FDA approved it as well.
Yeah, for these specific cluster 1 mutations, that's definitely, there's a certain side effects, but it's definitely something that we feel as a good option to have an extra tool. But this is not where we stop.
That's those are very promising and an excellent note to wrap up our session today. I want to thank all the panelists for an excellent, super informative discussion, and I want to thank all the participants for joining us and for submitting questions. Please visit the resources that both the American Association of Endocrine Surgery and the Pheo Para Alliance offers to patients. And I want to wish everybody a good evening, and thank you for joining us.
Thank you for having us. Take care. Bye-bye.
Take
Good night,
care.
everyone.
Bye-bye.